Hello and welcome. Thank you so much for joining us today. We're here to talk to you about how to hardwire equity into patient and staff experience. My name is Erica Rubenstein. I'm the Vice President of Service Excellence and Patient Experience at the Mount Sinai Health System in New York.
Hi, everyone. Thanks so much for tuning into our talk today. My name is Tara Ballon. I'm the Director of Patient Experience Data, Strategy, and Improvement for the Mount Sinai Health System.
Yeah, thanks, Tara. So we're going to start by just giving you some demographic information on who we are at Mount Sinai. We are the largest health system in New York City. We do have 8 hospitals total. One of them is on Long Island. Our workforce makes up over 42,000 people, and we're affiliated with the Icahn School of Medicine. So we'd like to start today sharing some steps to hardwire equity. We will show you those steps ahead of going through them all, but we first wanted to take a moment to talk about, we put the word practical in quotes for a reason. We do believe that these steps can be incredibly complex. They take a sense of being willing to be in a space of discomfort and sometimes even feeling like this can be an impossible feat to get to this goal of equity. But we want to reassure you that the steps that we've been able to take, we did together as an organization, and we are on our way and on our journey to achieving equity, although I will acknowledge that we do have a ways to go. One of the things that we've been trying to do on our journey is to look inward at ourselves. And so we'd like to take a moment, Tara and I both, before we start talking about our organizational sort of history around this and how we laid the foundation from an organizational standpoint, we had to start with ourselves and take a personal look at who we are. And so I just wanted to take a few minutes to acknowledge that I am a white female individual who is a leader at this organization. And with that comes great privilege and honor in the work that I get to do each day. But it also comes great responsibility. And I do feel that I must stay committed and put this work of equity and anti-racism at the forefront of everything that we do. I have taken it upon myself to ask my colleagues, including my colleagues of color, to challenge me, to give me feedback. And I've had to take a hard look at the work that I do and analyze and really think about, am I contributing to any inequities? Am I contributing to any racism that may be going on in our health system and in the work that I impact? And so I'd like to give Tara a few minutes to share her own personal journey as well.
Thanks so much for sharing that, Erica. You know, my mother is white and my father is an immigrant from South America. And there are times where I felt like both and neither of my parents' census categories. Because as you look at my fair skin, I am white passing. Someone like myself who can be presumed white, I now understand has reaped the benefits, the privilege of moving through this world in this whiteness. Um, Growing up, I appreciated the richness of the culture and the tradition that my Latino side of my family brought, but I really saw them struggle as they navigated this country. Learning English, getting the jobs they wanted, living in communities with people that didn't look like them. And I grew to realize that I did not and I could never share in those same struggles because of my skin color. Because skin color plays such a vital role in the way that we're perceived, I often wondered, how Latina can I really be? Where do I really fit in these two worlds? So questions like these really helped us distinguish between things like race and ethnicity and unpack our overall identities. And Eric and I are just so humbled to be able to share a little bit about how we as an organization have helped each other tell those stories and unpack our own identities. Back to you, Erica.
Thank you so much, Tara. It really has been helpful. to hear your story and to learn from each other, right? And I know, Tara, that along the way, you have challenged me on the work that we've developed, and we've really tried to learn from our colleagues as well. And we're going to share a little bit about that. So when we look at these practical steps, you'll see here that we've listed that leadership commitment as your first step. And although the other steps are absolutely critical, they're in no particular order except for that first one. The buy-in of leadership, having them really own this and commit to this, is critical. It has been in our organization, and we believe it to be so across other organizations as well, if we're going to get to a place where this work can be done. In fact, Tara and I feel strongly that without having our organization take these critical steps, we wouldn't have been able to follow and do the work that we do in our space of patient experience and staff engagement without them stepping forward first. And so we'll talk a little bit about how that happened at Mount Sinai. So our leadership commitment and knowing that diversity, equity, and inclusion are priorities was not a new concept for the Mount Sinai Health System. And this is really due in large part and much gratitude and appreciation to the amazing leaders that we have in our Office of Diversity and Inclusion. And they are really close colleagues of ours. We have worked the last several years to support their efforts, and we've been fortunate enough to partner with them in certain initiatives as well. One of my closest colleagues is Pam Abner, and she's our Chief Administrative Officer for Diversity across our health system. I've learned a tremendous amount from Pam, and I continue to do so from her and her team. And so it's with that foundation in mind that when we look back at the last 2 years, knowing that as we go through this pandemic and as we are currently going through this latest surge, that people of color are being disproportionately impacted. And as we experienced in the wake of the murder of George Floyd, we knew that we had to take a bold step. We had to do something that we hadn't done before. We had to take a very brave step forward and say, we're not going to go backwards here. We're going to make a commitment, and we're going to organize ourselves in such a way that we prioritize becoming an equitable organization and one that is on a journey towards being anti-racist as well. And so, again, I was humbled by our leadership when our CEO and the dean of our medical school in June of 2020 commissioned a task force. And they did this with the goal of addressing racism and getting to a place where we could be an equitable organization. That task force consisted of over 40 stakeholders from all across our health system at all levels. And they together created a roadmap on how we would do this work and how we would address racism. One of the things that came out of this in the last year and a half is that we added equity as a core value at Mount Sinai. And I want to just share with you how we define equity. We define it as creating a diverse and inclusive environment for our patients, students, and colleagues, free from bias, racism, and favoritism, to foster optimal care and just opportunities based on one's individual needs and abilities. So, in addition to making sure that equity became a core value and was very visible, we also made sure that as leaders, we were conducting listening sessions, and we were hearing from our staff as well as our patients on what was most important. You will hear Tara and I talk about this as we did this in the world of patient experience and staff engagement, but on a larger scale and from a system level, this was going on. There were town halls to message that this task force was now in existence and that this roadmap had been created. There was community outreach that went on as well. And most importantly, we knew that it was critical that as we were doing this work, we were educating ourselves and always taking the opportunity to learn. So we'd like you to pause for a minute and listen to a clip from this video that was launched by our health system to introduce the task force and the roadmap.
A year ago, there seemed to be a constant reminder that something wasn't right in the way in which people of color were being treated. The largest healthcare system in New York City could not avoid those issues, nor, as we began to think and talk about them, were we immune from issues around inequities. The leadership agreed that we should bring a group together and begin to examine how we were doing in that space and to have a deep conversation with a broad representation of our health system staff, how we could ultimately become an anti-racist healthcare system and a more equitable healthcare system for our patients and also for our staff, and to offer some recommendations and how we could be better. And that really was the beginning of a task force. The work of the task force began July of 2020. The expectations of task force members was that they would be brave, honest, authentic, and sharing how we were doing. And so we created a space to allow for pretty open dialogue, and then to be creative in thinking about what we could be.
Every newsreel, every social media scroll of a video was another hit of a reality that maybe I don't belong in this country.
I had my moment where I figured, that this cause is bigger than any one thing.
Why are we painted to be so many things that I feel like are very contrary to who we actually are as human beings? And I often wonder, does anyone see our humanity?
There's that fateful moment where I walk into the exam room for the first time and I don't look like what they think I sound like over the phone. And it's clear they were expecting a white man, and all of a sudden they have me.
And that is simply the way it works in this country. Can we change that? I hope so.
During the pandemic, my mother-in-law died of COVID, and within weeks, my father died. So my children lost 2 grandparents within a few weeks. COVID put the disparities and the inequity right on your face. You could not look the other way. You cannot ignore. You cannot pretend. That fact really created something like an awareness and a awakening in people to say, no, this is not okay.
The roadmap is neither a beginning nor an end. It's simply a next step in a decades-long movement. Our charge is to become an anti-racist and equitable healthcare institution that intentionally addresses all forms of racism and creates greater diversity, inclusion, and equity for our workforce and for those we serve.
Thank you so much for listening to this video. In its entirety, this video is about 12 minutes long. And I remember the first time I watched it back in 2020. It was so inspirational and motivating. Staff that I spoke to on various departments and patient units were sharing that they really felt like they weren't alone in this fight against racism and this movement towards being an equitable organization. Tara, I don't know if you had any comments about the video.
It's just so moving. I think the first time seeing it and seeing some of the colleagues that we work with every day share their very personal stories was moving. I mean, it definitely shed some tears the first time that I watched this, and I love that our colleague Angela called this an awakening, right? To call, really capture and let's move on this moment that we as a really as the world can seize this moment and make some good changes from this.
Yeah, it certainly was. And on that sort of notion of this being an awakening, one of the ways that we as senior leadership were able to move forward and really start that change from within, sort of like I talked about at the beginning with my own journey, was one of our leaders, who is our chief medical officer, Dr. Vicki Lopachin, reached out to Pam Abner and the Office of Diversity and Inclusion and said, I want to use our Quality Leadership Council as a forum where we can start this dialogue, where we can educate ourselves as the senior leadership of this organization, and we can start to learn and better understand how we can make these changes towards equity. So together, they were able to kind of turn this Quality Leadership Council that we have had ongoing for several years. This is a group that consists of our chief medical officers, chief nursing officers, leads for quality, safety, and patient experience across the health system, hospital presidents, and even members of our board of trustees. What they were able to do was really kind of flip the format of this meeting on its head. And instead of it being just a sort of one-sided report out, it became this very enriching conversation and discussion. What you see here in this slide are visuals of some of the books that we read. We read these together, and then we would come as a group. We would break up into small groups and get into deeper discussion. I was privileged enough to be a facilitator for several of these small groups, and these are actually ongoing. We haven't stopped since the summer of 2020 to read and work to challenge ourselves in these discussions. I will tell you that some of these breakout sessions have been very emotional. We have succeeded in being able to create a safe space for people to share. I will also say they've been a brave space for people to tell us, and share their perspectives on experiencing racism directly, and also experiencing and sharing what they didn't know. I remember one colleague who was a white male physician leader in one of the beginning breakout groups that we had, shared how embarrassed he was that he had gone through virtually most of his life, and certainly including medical school, without being educated on the impact of structural racism, and how it took him coming to these meetings, engaging in these conversations, in learning from his colleagues, that he was able to realize this, internalize it for how he impacts others, and he made a commitment to do better as a result. So we're completely inspired by our colleagues of color. We also brought them into the Quality Leadership Council as we included more and more leadership of color into our discussions to come and for us to learn with each other on these difficult topics. And so I'd like to share with you a little bit of data that we are that is important that we look at and that we take a critical look at here. This last summer, we were able to finally survey our workforce as a health system. We had delayed this survey due to the first surge of COVID, and we were happy to get it out for the month of June. And so well over 20,000 people took to the survey, and completed it. And these are the results of that survey. And as you can see, we were able to add questions around diversity, equity, and inclusion. And there is a correlation, right, between people's perceptions of DEI and their level of engagement within the organization. We did celebrate the fact that the highest scoring measures were in diversity, equity, and inclusion, and we're in that role of senior management. And it is those senior leaders that we're talking about here that we focused on first. So although we celebrated that, it also was a sobering message for us that we have to focus on our other staff members and members of our workforce. We have to get to all corners of our organization to be successful here. And so the bottom line was, we have a lot of work to do, and we're just starting in many ways this journey. So what we'd like to share with you now, we'll transition over to Tara, and she's going to take us through some concrete ways that we have been bringing this sort of momentum and this work in equity to our work and patient experience. Thanks, Tara.
Thank you so much, Erica. And it's data like what you just shared that is critical to looking at in all of our organizations. And a lot of my career has been spent with numbers and gathering data and analyzing data. And I'm sure many of you tuning in are no strangers to working with data, especially and patient experience. And it can at times feel like a dark tunnel that you're not really sure when the end of that tunnel is. You are analyzing and analyzing, but I promise when you're looking at data based on equity, dissecting some of your core metrics by race, ethnicity, education, zip code, that this data has light on the other side. It truly shines light on disparities, not only in processes that we see, like maybe surveying, but also in the care that we deliver and the perceptions of those care. So the first thing that I want to talk about that you absolutely need to have is a collection process. How are we capturing some of our most important equity variables like race and ethnicity? And I absolutely would not be standing here talking to you all today if it was not for the passionate work over many years of our Office of Diversity and Inclusion, led by Pam Abner and her team, to collect this data and to collect it in such a robust way. To not just make sure that the forms that in the documentation around this made sense, but the exact words that we were training and educating our staff to solicit this information were powerful and clear, and that staff were really engaged in the process of this and the design around soliciting this information. They also partnered really closely with marketing to create signage like what you see here on this slide that helps our patients better understand why are we asking them their race and ethnicity when they're coming in to the doors of our health system. Why it's important to know this, so to best customize and personalize their care. When you have such a great set of race and ethnicity data and other equity variables, then we could talk about what other sources may be out there in your organization to supplement this data. And for almost everybody tuning in today, you do have another source of this, and that is the HCAHPS survey. A part of that mandatory survey in the inpatient space is an About You section that you see on the bottom right-hand corner of the screen. There's 2 questions at the end of every HCAHPS survey that asks our patients to share with us their race and ethnicity. And we knew that we were, clearly asking HCAHPS for many, many years, given its mandatory space. And we had a ton of data there that was sitting as an additional source that we could tap onto. So how we use HCAHPS data as a supplemental source is to sort of help validate or sort of cross-check our EHR data, right? That's source number 1 that I was talking about, that premier source of collection from our patients at time of registration. Another way that you could think about using it is to perhaps fill in the gaps between each data sources, and they can really supplement each other and make each other more robust. Now you may be thinking, Tara, with all of these different sources, forward data like race and ethnicity, how do I know what is my source of truth? And the answer to that is your patient. It is whatever data source closely represents what your patients are telling you. It's not our guess at what the patient's race ethnicity is. It's not our perception of what it is. It's our patients, and it's as close as what they are telling us. So one of the first things that you want to analyze when you have this great set, this great capture for race and ethnicity, are your response rates. And I know that you may have the urgency, like I originally did, to want to just jump right into that outcome data, jump into your patient experience survey results, your clinical data, and just start cutting it by race and ethnicity. But I urge you to pause and really look at the underlying sample first. Look at who is being represented in those responses. And that was one of the first steps that we took. And this was really a huge moment for us. As you can see in this graph, we pulled one of our biggest hospitals, Mount Sinai Hospital's response rates for age caps by race and ethnicity. We were able to see that our white patients are responding at 2, almost 3 times the rate of our patients of color. We knew that this could be skewing our data. We had to look deeper. So one of the things that my data geeks on tuning in today may be thinking is, Tara, is that just representative of Mount Sinai Health System's population? Is that simply showing the patients that you serve? So we wanted to dive into that a little bit. Are these response rates simply showing us that this is the communities that we serve? And because, like I mentioned, ODI has been so committed to capturing this data along with the institution, we have actual data from our patients in terms of our actual population. And that is what you see here in this bottom left pie. You see about 40% of our discharges for this hospital in that year were white patients, but about 20% of these discharges were Black and our Hispanic patients. And that is a lot more than the sort of 7% that you see from the previous slide. We then wanted to really think about, well, we know that HCAHPS has its set of criteria, right? CMS has placed eligibility requirements, exclusionary requirements, and we wanted to layer those on to this graph to really see, is that what's tweaking the response rates? So we took that same population and we narrowed down and layered on the HCAHPS exclusions, the requirements from CMS. And we were able to see that chart looks pretty similar, right? It was not terribly tweaking the population at all. So then we were then labeled on who really responded from this second pie to HCAHPS, who chose to take that survey, and what does that look like? And this is where, again, we see that large sort of over-response in that blue, the large over-representation of our patients who identified as white. So this was telling us really that our data was skewed. Our data was biasing and potentially biasing the decisions that we make every day. So we knew that we had to try to have some more equitable patient experience survey data. We needed to hear more from the voices of our communities of color. Some of the things that we did was first partner with marketing to make sure that we had the right signage and campaigns around why this is important to us, why we really want to hear from our patients of color, for them to expect a survey in the mail, email, text. And this idea of a sign is, I'm sure, not unfamiliar to many of you tuning in. We all have had signage like this promoting the survey. But for us, we really had to take a hard look at what our signs looked like. And a lot of them did not have patients of color or even providers of color. So we totally redid the sign and tried to include more of our providers and the communities that we serve. The other thing that we did is we really tried to engage our staff in understanding more about why we see these disparities in response rates and partner with them in the design of these processes. So lastly, I want to talk a little bit about a really creative project that we did using these data sources, and that was to partner closely with our clinical data science team, who's an incredibly talented team of data scientists at Mount Sinai, and they were able to work with us to leverage AI, artificial intelligence, and our hypothesis was, can we predict patients that are at risk of having a suboptimal or less than perfect patient experience as measured by age gaps? And the goal of this was to really say, can we get to them before they are discharged? Can we change their experience? Can we create some positive, safe moments for them? Can we do proactive check-ins, rounding, and other things before they leave us? And the building of this model was really fascinating. And I'm certainly not at the level of data that our scientists are at here that built it, but they fed hundreds of clinical variables into this model to train it over time. Things like prior healthcare utilizations, comorbidities, demographics of the team, the unit, specialties, prior case specialties, prior diagnoses. And out of all these variables, the things that popped up as being sort of the most influential to the outcome were things like socioeconomic variables that we're talking about today, things like race, ethnicity, education, income, and even where we live, our zip code. So there was absolutely a call out here to make sure that those variables were front and center in the building of this model, that we had to make sure that those things were really taken into account into this model. And Erica, you were so close to this project all along. Do you have any other comments to make about the impact of this work?
Yeah, thanks, Tara. This has been a great project. We hope to scale it larger and more widely across the health system. But I will say that we're grateful to the clinical data science team for approaching us to partner with us on this. And also there was moments that, like I mentioned earlier, got uncomfortable, right? Because knowing what we know and what you just told us, Tara, about our data, and that it's really our white population that takes to the survey, and it's that sort of voice that we hear the loudest. We wanted to be careful here, and when that algorithm that the predictive analytics was sort of spitting out a list of patients for us to proactively approach was initially coming through, it was showing us that it was patients that were white, patients that were male. And I will say that immediately we got together with the clinical data science team, and both of us said, this isn't going to work, right? We have to make sure that the list of patients that we see accounts for our true representation of our population. So we want to make sure that patients of color, patients who have limited English proficiency, are a part of that daily list of patients that we outreach to. And in doing so, this project has been so meaningful to the staff that meet with these patients every day. It's largely our patient relations staff, and it's something that's been exciting for them and a positive moment for them to have during their day. And it's exciting to share that our preliminary data shows that we meet with around 155 or so patients a month as part of this initiative. And it's already showing an increase in the response rate of patients of color or non-white patients. They're taking to the survey and they're responding in higher numbers. And I will also just want to make sure to mention that every encounter that we have mentions the survey and how important it is to us, so that patients know that when they receive that survey, they can remember that moment. Hopefully it was a positive one that they had with our team, and that they can complete the survey.
That's amazing, Erica. It's such interesting work that really combines a lot of the patient relations and patient experience and data science components that I think we all live in. So I want to take a second to talk more about how do we really engage and develop a shared vision with our patients and our staff right by our side. And Erica alluded to the idea of a listening session tour really across the health system, led by many different groups. And we in patient experience wanted to make sure that we were supporting this effort as well. So some of our patient experience coaches who are really talented individuals who have a lot of amazing working relationships with staff were able to create safe spaces for staff to have these sorts of conversations, to ask them stories about their experiences, their own ethnicity, race, identity, create space for really every employee to feel seen and acknowledged in the way that they feel championed for, that they can rise to this work with each other and see their patients this way as well. So in this space, a lot of themes came up around safety tied to anti-racism. And all of these findings were shared back with leadership to really take action. The coaches also created a facilitator's guide to these listening sessions where you'll see questions like, do you see racism play a role in your work and how? What are your suggestions for how hospital leadership can create an anti-racist culture? And there were lighter questions in there to really start this conversation. Questions like any of us can start tomorrow with our colleagues asking is there a story behind your name, or tell me about your name, right? There's so much that we can learn from each other's name, history, experiences, and it's a really great way to start these sometimes difficult and uncomfortable conversations. Of course, there's always a quantitative way that we could try to gather this data as well. And as Erica mentioned earlier and shared with you, it was the first time that we were able to deploy an employee engagement survey across our entire workforce in June of last year. And we are so proud that we were able to get these diversity and inclusion questions with the expertise of our ODI team. And I really want to call out the partnership and the collaboration we had with Preskini in designing this as well. You know, originally the question set did not really have the right questions to measure where our organization was at in this work. And they were so collaborative and willing to work with us and our ODI experts to make sure that we had the right questions that we needed to measure us in our journey. So as Erica mentioned, if you're looking across at those overall scores in the far left, they were some of the highest scores we did have across our entire 1S survey. However, when you start to pull in and really look at different populations of our health system by race and ethnicity, you really see that we have some work to do across these populations. Where you see red, for example, meaning it is lower than the mean. Our Black and our African staff are telling us they're not really seeing or feeling the commitment to DEI as much as, say, perhaps our staff that identify as white. And another bucket in red here that you see is this really fascinating point of, you know, about 4,000 of our staff preferred not to answer. And that was a really interesting insight in itself, that perhaps those about 4,000 folks did not feel the psychological safety to provide this type of information. And this group also happens to be the ones that are answering most negatively about these perceptions and the perceived commitment of diversity, inclusion, and equity here at Mount Sinai. So this is certainly something that points to the work ahead.
Yeah, thanks so much, Tara. I think it is another awakening, right, to see this data from our staff, and our staff telling us that they're still not comfortable. They in many instances, they don't even feel safe sharing who they are, what their own identity is, let alone, you know, feeling like this is an equitable environment, you know, for them to fully trust and feel psychologically safe in. And I will say that in speaking to several staff over the last few years, we have heard from them how important this idea of equitable care is, you know, and part of those listening sessions that you talked about that our patient experience coaches led, when they brought those findings back to the leadership, what we heard from our staff is similar to what we heard in the comments of our employee engagement survey, is that what the staff want most is to be able to take care of our patients in a safe way and in an equitable way, and making sure that all patients get the same excellent care and treatment for whatever brings them in to our hospitals and to our ambulatory practices. And so with that in mind, we are also fortunate on our patient experience team to have very devoted and talented individuals in partnering with our patients. Our staff have told us that when they hear directly from our patients about how their experience was, they feel like they can really learn from that, and it really creates meaning with them to work alongside patients in sharing their stories, learning from their stories, partnering with them. A little bit of healing takes place, but also this sense of shared understanding. And so the visual here is of one of our amazing patient partners. Of course, she happens to be a woman of color, and she also happens to be diverse in the sense that she is a physician herself, and so she brings that really insightful perspective. She is somebody who we were fortunate enough to have volunteer for one of our focus groups that we were putting together as we were trying to change and improve the experience in our emergency departments. She participated in a focus group. She offered incredible insights. And then she was willing, like I said, to partner and share her story with our leadership. And these are difficult stories. These are not positive stories. For the most part, and we've really made a commitment to share stories like this that don't always have the happiest ending, right? These are stories from patients of color, patients who come from a transgender experience and maybe have been patients of our Center for Transgender Medicine and Surgery, patients who speak a language other than English, so another spoken language, or maybe they're deaf and hard of hearing and communicate with American Sign Language. And it's critical that we listen to their stories, as difficult and challenging as it may be, so that we can learn from them and then continue to partner with them so that they understand the changes and the steps that we're taking towards becoming a more equitable organization and an organization that is on a journey to being anti-racist. And I will just say before we move on from this slide that the patient that's pictured here continues to partner with us. She is committed to working with us and sticking with us as we're on this journey. She even wrote to us in December saying that she started off the year feeling really down and sort of almost cynical about the experience that she had with us, which was a little over a year ago. But she ended the year on a much more positive and hopeful note with all of the work that we've done to share her story and to learn from it. And so she was looking forward to the work ahead, and we're so grateful to her for that.
Thank you, Erica. That is so inspiring. It's so important for us as healthcare leaders and organizations to build this culture of storytelling. Another thing that's really going to help us make these stories more robust and to dig deeper is to, again, look towards your data that you have in terms of what our patients are telling us about the experiences they have in our systems every day. And here is where we can finally look at and get to think about taking all of those diverse variables that you work hard to capture and have robust processes for, and start to bring together those sources with other sources such as patient experience data and look at them cut one by the other. And here is where we do exactly that. This was actually a Press-Ganey tool that our advisor was able to provide for us, and we popped in the data and was able to see for our health system different senses of global metrics and what our patients were telling us they were feeling in these sort of global overall senses of care. And the biggest thing that probably jumps out at you as you hear is that column in red, our patients who identify as Asian are telling us that they're seeing and feeling less of a positive experience than our other patient populations. But we knew we had to go beyond these global measures. We had to dive deeper here. So this may look overwhelming, but it is really necessary to look under the hood of those global measures and to really drill into other areas of the survey, questions that measure perceptions of courtesy, of information and responsiveness, if care was personalized, if we displayed and acted with empathy, and we gave our patients the privacy that they deserve. And this is where we really start to see and unlock a lot of these insights. And I highlighted it in this black box here, the questions like in the personalized and empathy section that you see our patients that are identifying as Black or African American telling us that they're having less of a positive experience when it comes to staff including them in decisions about their care, or less of a positive perception of time that doctors spent with them. And this is really the level that we all have a responsibility to sort of get to look at this level of detail. But at the end of the day, these numbers are truly just the beginning of a very complex and nuanced and emotional story. So stories like what Erica shared and partnering with your patients to really work directly and hear directly from them is crucially important. And I will also call out that once we've seen data like this and shared this across their organization, there are so many departments that have took it upon themselves to always show HCAHPS data with these breakouts. I'll call out our obstetrics partners who have a dashboard where this is front and center, and they don't look at HCAHPS just in its normal categories. They always look at it broken out by race, ethnicity, and other variables, and that is really key here.
Yeah, thanks, Tara. I couldn't agree more. And that data for me, when I first saw it, was very eye-opening, and it just made me want to dig deeper. And it also did, I agree, you know, we really can't ever go back, right? We always have to now commit to showing that level of data, because that is really what our patients are telling us. And we have to always include that. And again, I go back to what I've learned from my colleague Pam Abner, that we always have to look through that lens of equity as we're doing this work. It's critically important. It's critically important to our patients and families that we serve, but also to the staff, you know. And part of looking through our work with that lens of equity is looking at policies, right? Because we're not going to be able to become an anti-racist organization, an organization that can truly call itself equitable, unless we're scrutinizing our policies and making sure that they themselves are equitable, right? There has been and continues to be a tremendous amount of work across our organization to look at policies, to look at clinical policies, for example, and see, are there things that we're mandating now for certain groups of patients and not for others, and those policies are being changed, and that is exciting. And so for our part in this, right, in the world of patient relations and patient experience, I was able to partner again with my colleagues in the Office of Diversity and Inclusion, but also with clinicians from across our health system, from people that are in risk management and patient safety, spiritual care, nursing, social work. And we were able to bring a group of us together from across the system about a year and a half ago to revisit a topic that we had started looking at before the pandemic hit, which was, how do we respond to the racist patient? How do we respond to racist and discriminatory behaviors from a patient or their family member? It was really something that staff were asking for guidance on, staff for years across our organization, and I'm sure we're not unique here. In fact, we know that we're not. Staff have been subject to racism and discrimination. It's traumatizing. It's damaging. It's heartbreaking, and it goes on daily. And I would say in the last few years, it's only gotten worse and gotten more prevalent. And so the need for guidance around this and the need for us as an organization to create a policy and say, this is what we want people to do. We actually want people to act in an anti-racist way, right? Which means to take action in support of an anti-racist policy or an anti-racist idea. It's not enough to say, I'm not racist. We have to be anti-racist. And for me, what that means is taking action. And so this policy addresses not only how to manage and even how to care for a racist patient, right? So in that moment, if a patient is targeting staff in an abusive way that is racist or discriminatory, or they are making a racist accommodation, how would you address those issues in the moment? But for the group of us that came together, we did some research, and that included listening to our staff at all levels. What we really wanted to make sure we did here with this policy was include how do we support the staff that are being targeted? How do we come to them during the incident, after the incident? How do we give them their own options and agency on how they will care for that patient, or maybe choose to step back and have a colleague or a peer step in and support them? But just making sure that whether you're a leader, you're a colleague, or you're somebody who is just passing by, that you don't ignore when you hear and when you see racism, that you stop and that you take action. That action should look like, quickly and clearly managing the situation, and also making sure that you stop to check in on your colleague that was targeted and making sure that they receive the proper support. In addition to just the policy, because what is it? A policy, it's a piece of paper, right? It's nothing unless we all know about it and do something about it. We're grateful for our partnerships with talent development and learning and education at Mount Sinai, led by our close colleague, Diane Adams, our Chief Learning Officer, along with, as I mentioned, the Office of Diversity and Inclusion. And together we came up with a skills-based training on how to coach and give guidance to staff for how they would handle these situations when they come up. So we include scenarios and role-playing opportunities, and these sessions have begun. They're also going to be available in an abbreviated version online. What I'd also like to show you is the visuals that sort of accompanied this policy. Best practice that we've learned from other institutions that have come and done this work before we have is that it's important to have signage. It's important to show on our walls and in our windows that we stand together against racism. And so you'll see the sign over to the left does just that. We make these signs available in different sizes. They can be clear decals that go on a window or a glass door, or they can be standalone signage that hangs on a wall. And in the middle here, you see a sign that talks about how to report, what to do when you witness this yourself, whether you're a staff member or you're a patient, right? We want it to be well known and well communicated to our patients, our families that we serve, as well as our staff, that this is not okay and we will not tolerate this. We also have been doing a ton of events around this and making it known. We've been holding different forums where we discuss this. And over on the right is an example of an event that took place at one of our hospitals in the fall. This was an amazing event where I was invited to join, but was so blown away by the leadership of our Mount Sinai Queens Hospital, who really have owned this policy and the responsibility that it carries. Each leader shared their own story of how they've been promoting and exhibiting the work of this policy. And we hope to have more conversations like this in the new year.
Thank you so much, Erica. This piece around the policy is so critically important to advancing equity. So we're going to start to wrap up here and end with sort of our last of our 5-step, although not sequentially, 5-step framework here. And we're going to talk about something that is really important, but sometimes we forget to do this, and that is communicating whatever and anything that we do. And it's this sense of sort of over communicating whatever steps we are taking in our journey to become more equitable organizations. So one of the ways that we play our role here in patient experience and communicating is that we hold quarterly patient experience forums. And these are forums that happen via Zoom to really maximize attendance. And we're really happy to share that our last forum that took place had around 600 people attending it. And we focus on all sorts of different topics related in patient experience. And we have a formula where we really try to bring together our staff voices and our patient stories. So we always show a patient story, and we actually bring in the care team and the folks around that patient to help care for them. So it's a really unique perspective that we bring together leaders, patients, and staffs to all rally around and talk about patient experience. And we've held several around the topic of equity, but we always try to include diverse perspective, even when the topic isn't equity, because in a way, it's always about equity. The other way to continue to remember to use all different communication channels, and I know most of us probably have things like system-wide broadcasts, especially during such a time as COVID and wanting to have, quick blasts out to your workforce. So utilize channels like that to keep your organization informed about the work that you are doing around equity. This is incredibly important. So as we look to wrap up today, Eric and I shared today with you some steps, a roadmap, but really what's important to remember is the markers on your roadmap and our roadmap may be similar, but the journeys that we take to hit them are going to be different. And none of them are perfect. As we've all learned, there's no perfect COVID-19 response plan, there's no perfect vaccination plan, and there's certainly no perfect thing as an equity vision. But create a culture where you can iterate, where you're continually learning from each other, continually listening from all voices and building that inclusion, and get comfortable with the discomfort, get comfortable with failing, and really just commit ourselves to be willing to make this change over time and be better. Erica, do you have any final comments?
Thanks, Tara. I was thinking the same thing. It's really getting comfortable in the uncomfortable, right? Which is a lot of what this work has been about. We want to thank you all for listening today. We also want to say that we hope to learn from you all as well. And we hope that today opens up a dialogue. Tara and I want to be available for any ongoing conversations or questions that you might have. We're happy to share any of our work that we're able to with you. And we hope that we'll learn, like I said, from you all as well. So thank you so much.
Thank you so much.